And we are going to review some of the cases that actually we have seen and other ones that are new. So this male, 74 years old, has progressive increasing headaches, no recent trauma, and is on anticoagulation. And this is the CT. And is this normal or abnormal? Abnormal. Okay? Everybody, so we have subdural lesions bilaterally, right? So these are isodense subdural hematomas. Sometimes these are big, bilateral, but they are big. It's easy to depict. If they are small, it's more difficult to depict. Why? How are you going to see when they are isodense if there is or not a subdural collection? You follow the cortex and the sulci, and you see that the sulci will end here. So here has to be the end of the cortex. Whatever it's here is at the subdural space. If you want to be sure, you would just give contrast and you would see all the vessels displaced here. Okay? Very easy. And if you obviously take your pictures and do like reformatation on coronal view, it's even easier to see where is this, the end of the cortex and the subarachnoid space, and that this lesion here is at the subdural space. Here it's more difficult, but again, you follow the sulci and you know where the cortex will be. Very good. Typical location. Is this a subdural or an epidural hematoma? Because it's bilateral, or it's passing the falx, or it's bilateral. So it's going here, does not pass the falx because it's bilateral. Okay? If it was epidural, could pass like this. Very good. Now the images, they are typical image of a subdural lesion, and this will be as in terms of topography. You see, can come here also around the falx, and here also. Another case. So this low density foci inside, we already know what this means. Acute bleeding, very good. So you see where the cortex actually ends. Okay. Female, 46 years old, progressive headaches, and there was an abnormal finding on the CT. And these are the images. So who has the microphone?
I have it.
Good.
I think there's an intracranial extra-axial mass. Perfect. With the CSF cleft around it. And I think it's a sphenoidal wing meningioma.
Why do you think it's actually from the sphenoid wing?
It's anatomically.
You are completely right.
I think anatomically it's just around that area. Out there.
What is happening here to this bone here compared to the other side?
It's a bit thicker.
Thicker, so you have a hyperostosis associated. Very good. So we have clearly seen that this is an axial lesion. You see the CSF cleft, you see the gray-white matter displacement, you see the vessels surrounding the lesion at the CSF space, and you have bone changes associated, okay? So everything fits for an extra-axial lesion. I have seen this image when we are doing the lecture. As an example, you see the complete CSF cleft around it. So what is happening with this meningioma? What is happening here inside this? What? Calcium, right? Because it has low signal, and maybe you will also have some vessels. Okay, you give contrast, what do you see?
I see intense contrast enhancement. Well, it's a bit heterogeneous, probably due to the calcifications.
Very good. So the solid non-calcified component will enhance, the calcium components will not enhance. And why is this enhancing here?
The dural tail.
Okay, very good. So it's a dural tail, and it's a reaction of the dural that is not pathognomic of meningiomas. There are other dural diseases that can have dural tail, but it's commonly associated with meningiomas. And it's important to mention that on the reports, because actually we don't know if it's just a dural reaction or if the meningioma has actually an extension to that dural area. No brain on this one. So female, 54 years old, with seizures. Actually, the first seizure. And now.
You see a large hyperdense, partially calcified mass. I suppose in the left interventricular region.
Are you sure? Because this is a tough case. Just showing the CT, thin slices, and we have large edema associated with the lesion. On the other hand, if it was such a lesion inside the ventricles, shouldn't we have like hydrocephalus or blocking the CSF? It's difficult. Huh? No, but it could be any part of the ventricles. It could block just from the atrium. You have like an incarcerated atrium. Yeah, and calcified, okay? And it's an adult patient, so all those pediatric tumors are out of our consideration. But you are right, so you want to see anything else more? Yeah, coronal, or I give you the MR. Can you comment on the images that we have? So T2, flare.
It's a lot of edema around the lesion. You see, I think it's buckling of the axial ganglia.
It's compressing the area. We don't know where we don't know where it's located. Huh? So if it's because the differential diagnosis would be completely different if it's an intraaxial or an interventricular lesion. Okay, the possibilities are different. Going to show you more images. So you see that there are some cystic components. The calcified portion was here, and so this should be some associated flow voids inside the lesion. So whatever the lesion is hypervascularized. So you see here the atrium, and then the occipital horn would continue like this, and you have the lesion here with tremendous edema. And these are the images with contrast.
Bright homogeneous contrast.
And intense contrast. So if it was an intraventricular, we would consider the possibility of a meningioma.
Ependymoma?
Yes, could be ependymoma, but very, very homogeneous. Don't have cysts associated, but it could be. What does this two image, so ADC map and perfusion CBV map tells us? So the ADC, do you think it's increased or decreased? The levels. It's decreased, so hypercellular tumor. And the perfusion?
Hypervascularized.
Hypervascular. So hyperperfusion. Very good. So a very cellular tumor. Now we did a reformatation, try to understand, and maybe this image will allow us to understand if it's intraventricular or extraventricular. You see? It's a strange oblique view. So lateral ventricle, it continues here. You have a cleft there, and you had also a cleft there. So it was an intraventricular lesion. Okay? And it was indeed a meningioma. Okay, so the important part here is actually to try to understand where is the location, and then the location, the age group, and then with the age group you have shortened our differential diagnosis. Okay, 52 years old, male, headache, vomiting, and ataxia, and this we have seen. So what are actually the features? So we've seen on the lecture that this is an ependymoma in opposition to the previous one that was a meningioma. What are the features that help us to think on an ependymoma?
Well, first of all, the border is irregular. It is not that smooth. The other thing is that it is heterogeneous and parts above pointed foci of calcification in different places.
Yes.
And also
this plastic component that it goes through the foramen.
the foramens of the fourth ventricle. It is
and then the possible areas of bleeding inside. Okay, we don't have the T2 star here, but these are important points that you think on an ependymoma. Okay, male, 44 years old, headache, reduced vision. Actually, it was a visual field defect. And what we have here?
There's a mass lesion in the in and above the cellar, and it's enlarging the cellar itself, so it must be a slow-growing lesion that has modulated the cellar, the bone, and it is extending elevating the optic chiasm and extending laterally, at least on the right, at least towards the vessels, the cavernous sinus and the carotid artery, potentially invading the same. I would need an MRI to confirm that.
So what would be your main
differential would be also because of the slightly increased density would be a primarily intracellular tumor, a macroadenoma.
Yeah. And let's see the images on the MR. So slightly hyperintense due to cortex on the T2 flare. Now in the T1, you see the lesion, you see the area of compression of the optic structures that are deviated upwards, the bone remodulation and enlargement of the cella, and there is a contrast enhancement of the lesion. So now comes the tough part. Would you think that this is invading or not invading the cavernous sign? We can look at the left and the right side and try to...
Kind of at the edge from what you said before, not more than 180 degrees might just displace it.
Yeah, so it might just actually be displacing. We are not sure, and there are not absolute figures on that, but probably it's just displacing the arteries, okay? So, and this is a crucial information to give. Okay, very good. So, 64 years old, subacute thick nerve cranial palsy, and this we have already seen in the lecture. And what I want you is to point it out, where is the lesion, and what would be your differential diagnosis?
There's a lesion in the right paraciliar region.
Right
It's
cavernous, right? So if you see, it's here, and it's here, okay? Cavernous.
and it looks like an extraaxial lesion.
Okay. So what can we tell regarding just these sequences about the lesion? It's the low signal on T2, right?
It does not follow the liquor signal.
Okay. Has contrast enhancement.
Enhancement. It's in solid lesion.
Okay. So what would be your differential diagnosis?
It can be again a meningioma.
Could be a meningioma,
It's an
especially with the low signal on T2. Yeah, that was the case, because low signal on T2. Well, schwannoma tends to be brighter on T2. It was not being. Hemangioma, which is very rare, it's also brighter on T2. And the final one would be the possibility of being a metastasis. Okay, so I would put meningioma, lymphoma, and metastasis, taking into consideration the age group. Okay?
Or perineural spreading of a
Yeah, it had to be
carcinoma of the
yeah,
base.
if it was a perineural spread, but we don't have anything else. So the differential would be that the meningiomas, they tend to be very, very slow growing in opposition to the other lesions, and that's actually what happened. We followed the patient, and the lesion actually increased and could not be a meningioma. Very good. 32 years old with headaches. And this we already seen on the lecture. So just remembering, where is the lesion and what are the important findings that help us to make the differential diagnosis. You can pass the micro. You see the lesion? You don't see the lesion. Okay. So let me help you. The pons looks like this, a little bit rounded. You see? There is something there. We don't see it, but we just see the mass effect. Okay? So this is a T1, and we go to the T2, in this case, dark fluid. And we should see the CSF like this. Okay? Like this here. What is happening here? Is filled with something that is not CSF. So it looks like CSF on T1. It looks like CSF on T2. But on FLAIR images, it's not. So if I give contrast, it was not going to enhance. If I want to be sure, I would ask for which sequence? DWI. Okay? And there you have it on DWI on the coronal, and you can compare with the coronal. You see the full extension of this cystic lesion with restricted diffusion. So this would be an epidermoid. Very good. The question being, for the surgery, it's important to try to evaluate the full extension of the epidermoid. And so play with the different sequences, because this epidermoid comes from here till here. Where is it? Okay, everything is the epidermoid. Okay, so diffusion and T2 flare are useful also to see the full extension of the lesion. Well, this one I did not show. 4 years old, seizures. Where is the lesion? Is beneath the hypothalamus. Very good. Can you point it out? So, you have the pointer. Correct. So we have a lesion here. So reviewing anatomy, so the spinal cord, the medullary, the pons, the midbrain, the floor of the third ventricle should be like here. So you have something that is not at the cellular, it's supracellular, and probably it's based on the floor of the third ventricle, where is the hypothalamus. Okay? And clearly you see here the lesion. Again, the lesion here, here, and we give contrast. It's not cystic, it's actually very solid, but we give contrast and there is not lesional contrast enhancement. So, what can this be? It would enhance? Yeah. Could have some mass effect and some edema. This seems to be well tolerated without edema. Or, the name is not that one, is hamartoma. It's very typical location of hypothalamic hamartoma, presenting with seizures, pediatric population. Differential diagnosis, optochiasmatic astrocytoma. The optic nerves were actually normal. You see the optic nerves there? And then you see the chiasm and everything, it's actually completely normal, and there is no edema, no contrast enhancement, so no optic nerve, also edema, so it was hypothalamic hamartoma. On the coronal view, you also see the here on the T1, you see the optic nerves there, and it's okay. You see that the lesion, you see the base of the hypothalamus and the pituitary stalk, and the lesion just starts there at the floor of the third ventricle with no contrast enhancement. Very, very typical of hypothalamic hamartoma. Okay? They grow. They have to be taken out. Okay, male, 41 years old, progressive headache after head trauma. No clue? Who has the micro?
So it's extra axial hyperintensity on the left side, first frontal.
Extra axial, right?
Extra axial. Did I say intro?
So
extra axial.
Middle fossa, middle cranial fossa, and going into what is this? Sylvian fissure. It's opening the Sylvian fissure, right? Very good. So this is hyperintense. Do you see any other lesion? You think this is the same lesion? Is the same everything? Okay, extra-axial lesion. So you have something is happening here. Something is happening here. We are not understanding this very well. If it was not for this upper part, if you just look at this image, you would say that this is what? Arachnoid cyst, right? Okay. I give you the FLAIR images. Now you see more things. Can this be an arachnoid cyst with high signal on FLAIR? Not usual. And you see what is happening in this sulci? The patient had a brain trauma, head trauma, so this could be what?
Subarachnoid bleed.
Traumatic subarachnoid hemorrhage. And this could be also what?
Dural hematoma.
Subdural hematoma. Okay. Does this look like a subdural hematoma?
No.
No. Okay. Now you have the T1. This looks like a subdural hematoma, right? And this. And this is the diffusion. Well, looks like different from here to here. Seems that this has evolved more to a chronic phase than this one. So, well, nobody told that this could be fat. Can this be fat? It's hyperintense on T1. No, it was not fat. It could be been a dermoid cyst, right? It's not fat. Leptomeningeal cyst, neuroenteric cyst, very lateral. Growing, but the cyst has no CSF signal intensity. Epidermoid. Okay. And this is the T2 star, so you see that there is blood there, and it looks like that there are two different things. Well, we did the follow-up, continue to do the follow-up, and now if I show you this picture from the beginning, you would say that this is what? What? An arachnoid cyst, right? So the patient had a trauma. Hemorrhage inside an arachnoid cyst, okay? Yeah. The only thing is that that blood will actually be reabsorbed over time. Okay? Okay? Very good. So this was an hemorrhagic hemorrhage into an arachnoid cyst. Okay, last case. So female, 44 years old with seizures. And again, to end and end.
Well, there's this mass on the left side.
Good. So can you tell if it's an intraaxial or extraaxial lesion?
An extraaxial lesion.
Good. So it's slightly hyzo in T2. You see some dark areas and other small dots. So these dark areas could
Maybe
be what?
these are calcifications.
Calcifications. The smallest one could be what?
Flow void.
Flow voids. Very good. Now you give contrast. Now, or I'm having a problem, or I'm seeing a lot of lesions. This is what you were talking about, right?
Yes.
And this.
Yes.
What about this? And this.
The dural tail sign? No.
It's very thick and irregular for a dural sign, the dural tail sign.
Is this like
and the lesion is here.
leptin
Could be
meningitis? Or
Could be 2 lesions. 2 of the same kind. Actually, this patient has been operated. Okay, this is a post-op. So I have one here, another one here. More lesions or not? NF2. Very good, very good. So we have multiple meningiomas. We have schwannomas associated bilaterally. And this, whenever you see multiple meningiomas, multiple schwannomas, and you should scan all the dural axis, because you have another one there, another one there, and another lesion there. So you have meningiomas and schwannomas all the way down. So multiple meningiomas, nerve tumors, neurofibromatosis. Okay. So maybe you have just 1 minute. Okay. Female, 53 years old, headache increasing with Valsalva maneuvers. Where is the problem?
The venous system.
In the venous system. If it's not in the venous system, where is the problem? Craniovertebral junction. Okay? It's very typical. It is where we have to look at it. So, you see the lesion? Everybody seeing? This is a tough area. You see the lesion there? So this is the spinal cord, medullary junction, medulla that is compressed and displaced, and you see the lesion here. Okay? So it's an extra-axial lesion at the craniovertebral junction. So what lesions can we have here? Just on the differential. This one. So if it comes from the meninges, can be what?
Meningioma.
Meningioma. A schwannoma of what? Lower cranial nerves. So you need to look into the jugular foramen and hypoglossal foramen to see if they are enlarged. Can be metastasis, can be bone, primary bone tumors, and another lesion that can come from the jugular foramen. Paraganglioma, okay? And then we close this differential diagnosis of this area, okay? Very good. So where do you think the lesion is coming? Now we see on the sagittal view, you see, and on the coronal view. We have seen this on the lecture, so it's not very difficult. You see that there is attachment
from the dura.
On the dural. Important thing here is to exclude. You see that the vertebral artery is passing very close to the tumor, to exclude the possibility of having an aneurysm, even a partial thrombosed aneurysm of the V4 segment of the vertebral artery. And then you see we did a time of flight just to be sure that it was not a vessel and not an aneurysm. And you see that this location you can have a tumor coming from the jugular foramen or the hypoglossal canal that is there, and or the bone or the meninges. In this case, it's clearly a meningioma. Okay, important relations. Topographic that you need to report with the brainstem and with the vertebral basilar system. Okay? Very good. Thank you very much.